that was my next question, to pivot away from your school life and focus more on home. My struggles mostly came from my home life, from the abusive upbringing or an abusive environment I was in. Can you relate to that, or were your parents, I don't know, how is your relationship with your parents now?
Oh, it's great. So yeah, my mom's one of my mom and dad are we're all very close. And as we get older, it kind of turned into more of like, now we're just kind of friends. I look forward to visiting them. So like I said, we don't fit the mold in that way, right? Where we all of us have great relationships. I talk to my sister and my brother almost every day. I visit my parents at least once a month. They're about an hour and a half away.
That's nice, man.
Yeah, so I was, so lucky. I can't imagine. I think about this a lot where, I wonder what would have happened had I had that predisposition, right, to mental illness and didn't have that support, right? Didn't have parents that cared, or even, being in America, right? If I didn't have parents that could help me access that treatment, right? That was,
Yeah.
was fucking expensive, man. Like, and
Oh,
insurance.
well, yeah, I bet. I mean, the American healthcare system is completely different to the one that I've seen in the UK. So, yeah, I'm glad you had that support. Carry on. Sorry.
Yeah, so I'm grateful about that. Constantly, we all got really lucky in that regard, and it shows in our outcomes, right? Where we were all able to like get it under control and manage it relatively quickly, which I think was good. So it kind of does work against a little bit. There's kind of two schools. I shouldn't even say two schools of thought, right? We kind of entered this trauma informed period where we're all really dialed into it, and I think that's amazing. And one of the really great kind of books. I'm sure have you read Body Keeps the Score
Oh,
by
yeah, fantastic book. Basil Van der Kolk, I think it
Mhm.
is. I'll put a link in the description for anyone who hasn't read it. It's a fantastic book, trauma, focused on trauma.
Yeah, and and it's interesting. That thing's been on the bestseller list since like 2014, and it's a pretty dense book. Like it's written for clinicians, but people just grabbed onto it, right? Because it really speaks to something in people, and he really gets into sort of how complicated that can look. OCD is a little different in that there is a really big hereditary component, right? And we kind of look at identical twin studies to see that. So between
Okay, cool.
fraternal twins, which my brother and I are fraternal twins, you'll see that like 20% crossover, right? And
Forgive
then
me. They're not where you're not identical.
yes, when you're not identical.
Not
So
identical.
my brother and I genetically are the same as like my sister and I would be, right? Just because we just happen to be born at the same time. But when you're an identical twin, you share 100% of the genes, right?
Sure.
So one way to look at heritability is to say, okay, well, what percentage of fraternal twins are likely to develop this, and then what percentage of identical twins? And the identical twins is like 80%, right? So like substantially higher. So that genetic component is just really huge right there. Now trauma can look a lot like OCD, right? Where if I experience I think even COVID could be a good example. Like if I, had a family member that got put on a ventilator and died horribly, then suddenly I'm afraid of a virus and you're taking all those precautions, it probably would have looked a lot like I looked, right? As I was like washing my hands all the time and, checking for symptoms and stuff. The difference is that at the core of that is an intrusive memory that sort of has to be dealt with. And a lot of times with OCD, there isn't quite that thing that you can focus on, right? You have to focus more generally on the themes and kind of work, both respond well to exposure to a degree, right? But you're kind of targeting different things, if that makes sense. So yeah, that was a little bit of a tangent, but
That's the point of these conversations. I'm enjoying learning. I know very little about OCD. One thing I haven't brought up with you yet, I always had this thing I used to do as a child, and sometimes I still catch myself doing it now. If you have a rectangular table, I wouldn't like to walk in line of where the corner is pointing. So I'd always try and step over it. And I don't know, that was my little tidbit of OCD that I have. I find it uncomfortable to do that, to the point now where I will deliberately do it to unfuck my brain, to make sure that I'm not, I don't know, susceptible, or letting my weirdness, or my brain beat me. As a counselor, what does that say to you? Does that suggest anything to you about me? I'm curious.
Well, one way that I like to think about this stuff is I'm not measuring whether or not a symptom is there. I'm measuring the degree in which it interrupts your life. Okay. So, we think about OCD and there's this huge spectrum, right, of symptoms. I think a lot of people have a couple hiccups, right, in terms of like the example that you just gave with the table or, maybe liking things a certain way. And it stays like subclinical, right, for most people. So, it wouldn't tell me much until, it starts affecting your relationships or your job or your goals or, how much of your time is sort of being used. Because no matter what symptom we look at, we all have like some, these like quirks and things that aren't perfect about ourselves. And one of the issues that I have with our healthcare system is that we sort of pathologize totally normal behavior, right? Or totally normal responses to bad situations. And that is one thing that I want us to kind of move away from and just look at like, is this holding me back in some way?
Editing a video today, I'm trying to think what the participant said. Trauma is a perfectly normal reaction to a very abnormal event. That really resonated with me. I really like that. Like you've done whatever you can in the moment to rationalize with your young brain this terrible, awful thing that's happened to you. And maybe it manifests, for me, manifesting in not wanting to stand in the corner line of a table. I've no idea where that came from. And I've never thought about this. I'm trying to think why I might do that. I can only assume that it was a way to distract myself in the moment from things going on. Like it was a little game maybe I could play with myself. I've really no idea. Couldn't tell you.
Yeah, and I think like a lot of these like sort of traits that we have, a lot of times we aren't going to get the answer. We aren't going to be able to sort of draw a direct line between it because, and when I talk to these psychiatrists or people on my treatment team who are so knowledgeable and I respect them so much, a lot of times, you'll ask them these questions. Why does this happen? How does this medication work? And a lot of times the answer is we don't really know. We're just guessing. So yeah.
It's a work in progress, I guess.
Well, yeah, we got to figure it out. I mean, if you think about these kind of scope of medical science, right? Psychology is in its infancy. I mean, say, you think about, Freud was kind of the pioneer that got that started, or, one of them. And, he's operating, early 1900s. And so, yeah, I mean, 100 years, that's nothing, right? So we're still just babies,
No,
figuring.
I've said this to other people as well, that I think the psychology field does not understand mental health. We're still trying to fit people round pegs into square holes, and we're trying to fit someone with a series of symptoms or behaviors, diagnoses that completely overlap. Just because you've got this, and this doesn't mean you have bipolar. Just because you have this, and this doesn't mean you have ADHD. You have a set of environmentally influenced personality traits, and it's not something you're born with, it's something you learned, and I think we need to do a lot of work on it. It really frustrates me, the use of pills and medication to treat disorders. I don't think personally, I don't think they've really ever helped me, and that it isn't to knock them for anyone who takes them. For God's sake, keep doing what you're told to do, and if it works for you, it works for you. But antidepressants, for example, I never found to work for me. What I found to work for me is understanding why I am the way I am, what's happened to me, taking control of my own psychology and saying kinder things to myself than the negative, nasty things I would say. I'm curious, talking about medication, if there are medications used with OCD. I'm guessing there aren't so many. Is that right?
So, the way that they tend to medicate OCD is through selective serotonin reuptake inhibitors. The difference with
SSRIs,
so the difference with OCD that you would see we are just using it for generalized anxiety disorder or depression is that the dose that they use is much higher. And it,
Sorry, in depression, the dose is higher.
no, I'm sorry. The dose for obsessive compulsive disorder is a lot higher. And you do see, a reduction of symptoms with people pretty like consistently, right? I mean, however, once you come off the medication, you kind of go back to square one, right? You decompensate. And then when you're taking the higher doses of SSRIs, you tend to have some more side effects. I think it can be a useful tool, but, so for me, just so what happened to me, I kept going to the doctor because I had all these like health concerns, and he knew it was anxiety. So he was like, "Here's an SSRI." Put me on like 10 milligrams of Lexapro, And I had nothing but terrible side effects. It didn't touch my anxiety. And, when I went and got treatment at a clinic, the first thing they did was take me off of it. Thank God, because it was pretty miserable. And then through the, behavioral therapy, I, put it into remission, right? I wouldn't even meet criteria for OCD anymore. And trauma's like sort of a similar way, right? They have medications that can like kind of treat some of the symptoms that come up, but you're going to have a much more reliably positive response from some type of exposure therapy. I'm pretty cautious to, poo-poo medication altogether. I think it's a great tool. I think if you're depressed, about 50% of people are going to have a good response to it. And I think we should use every tool that we have, if I'm being honest, right? And some people are not willing to,
100%.
yeah. So some people are not willing to spend 2 hours a week sticking their hand in toilets, right? Or going through their trauma or talking to someone. So if they're willing to take a medication and get some relief to that, like cool. In terms of best practices and what I would want to see first, because there's so much baggage with medication, give some of this other stuff a shot, maybe, and see what helps. We have some really exciting stuff kind of coming up. At my level of care, the intensive outpatient level of care when symptoms are that severe, I really like both, to be honest. I want to be hitting it kind of on every level where, if they're open to it, we don't, push anyone to it, but medication assisted treatment, especially with addiction, radically improves our outcomes, right? With people with severe, depression, anxiety, stuff like that, do both, right? Is kind of like, what I kind of like to see with people. But everyone's different, and we really have to, respect and work with what our patients want, right? That autonomy and kind of go from there. I do think, because in my case, a general practitioner, someone who doesn't specialize in psychiatry, threw one medication at me and never followed up, and I had no response at all whatsoever. That's like not the way I want to see mental health care at all, right? I want psychiatrists and people who focus on psych, because it is such a challenging field, right? And that's always my whenever someone's dealing with a mental health issue, I'm like, find the specialists, right? Don't go to a generalist, and find someone who deals with that every day, right?
No, you wouldn't go to a pediatrician if you needed surgery. You'd go to the person who knows what they're doing. It does take time. You have to go and find a specialist, and you have to go and find the right specialist who understands you. There are some crappy therapists out there. I've certainly seen my share of them who, I don't know, for whatever reason, they aren't as good as they could be. I think I'm always a little bit wary personally of a therapist who doesn't have any of their own trauma. I think there are some therapists out there who have said, oh, psychology seems quite fun. So they go to university to study psychology, and then they become a therapist, and they'd say, well, what does the book tell me about OCD? Okay, I've got to do this. Whereas I'd rather go and see someone like yourself who does understand it and who has experienced it and can tell you the nuances of why exposure therapy and putting your hand down a toilet and carrying these paper clips around might be good for you. I must put your contact information videos in the video description, so if anyone comes up against it and likes your vibe, that they can get in touch with you. I'd much rather see a specialist who understands narcissistic abuse for myself than just any old therapist. But it does take time, and you've got to find the right person.
Yeah, absolutely. And sometimes, you can have a really good therapist that just isn't a good fit for you. Yeah. Or like you said, even a really good specialist. And if you're not vibing and you're not, I always tell people to be really picky with the providers in your life, right? I mean, if you don't like your therapist, switch therapists. Like whether it's a personality thing or whatever, we're not a good fit for everyone, and that's cool. And a good therapist is not going to, it never feels awesome when someone's like, hey, I'm going in a different direction. But I would much rather someone do that than like 6 months down the road, we're not getting anywhere because they're not comfortable with me or doesn't want to open up or whatever. And being a trauma therapist, that happens all the time, that people are like, hey, I'm a lot more comfortable talking to a woman, or hey, you remind me of, my, stepdad or something, right? And I'm just not going to be able to open up to you. I'm like, okay, yeah, let's find someone that will,
I decided lately I didn't want to see a female therapist anymore because most of my trauma comes from my mother. And I realized seeing my last therapist, that was often triggered by some of the things she would say. I actually ended up binning her off because she complained about me missing sessions to go to my dad's funeral. And I just got furious at her. Yeah, I got furious at her for that because she made it all about herself. And I just thought, I just saw too much of my mother's behavior in her, and I realized I'm out. So I've been looking to find a male therapist ever since. I had a point I wanted to say, and again, it's lost me.
But we were talking about being picky and how like having those
Oh,
preferences. Yeah, listen to that.
forgive me. I just remembered what I wanted to say.
Good.
I think that I worry that a lot of people with mental health issues and disorders, whatever, because they've come from a background that is, say, abnormal, if there is such thing as normal, or perhaps abusive or neglectful, sometimes you don't have the necessary self-esteem to stand up for yourself and say, hey, this isn't working for me. And you sort of just trundle along with what you've been given. I wonder how many people in America have been to a general practitioner who's ended up throwing Prozac at them or the other drug that you mentioned and thought, oh, okay, well, I've got this one now. Like, I'm just going to take it. And then after 3 months, it's still not working. They think, oh, well, it must be me. So I'm just going to keep taking it. And unfortunately, that takes time to develop that, not willpower, but the self-love for yourself, to believe in yourself and think, no, fuck this. This isn't working. I need to find something different that works for me. And that isn't easy for everyone. It does take a bit of time, I think.
Yeah, I mean, we're essentially asking a traumatized person to stand up to an authority figure in a way, right? And yeah, is everyone going to be ready to do that? No, but yeah, and it is really unfortunate. You asked like how many people there are that like stick with a therapist that isn't working, and it's a lot, right? I'll get people to me that they've been doing talk therapy for years and years and years, and they've never been introduced to some of the most basic interventions, whether it's for trauma or OCD or depression. Like they haven't even done the meat and potato stuff, and they're sitting here told they're treatment resistant. It's like like that's stupid, right? That's a shitty therapist or whatever the practitioner is, because yeah, there's a quality control issue for sure. So yeah, like that's the takeaway that I really want is like if you've been doing talk therapy for a long time and you're not getting anywhere, well, find someone who does a different type of therapy. And another thing is if you're seeing a therapist and you have no idea what their theoretical orientation is or how they approach problems, like you're just kind of coming in freak of the week stuff, like you're not getting good therapy, man. That sucks. And move on, right?
Yeah, for sure. But also the shame and the stigma around mental health also creates that barrier. And that's the whole point of the podcast, is we can come and talk about these things. I think maybe OCD is slightly different. If you say OCD is hereditary, I didn't know that, but I'm more than willing to believe you. All right, let's pivot again and talk about addiction,
Mhm.
because that's something that we've not necessarily covered so much. We've spoken more about OCD,
Mhm.
but forgive me. You said that you see a lot of outpatients in addiction, but people who are really heavily addicted, and particularly about substance abuse. Is there a particular substance that you're focusing on? Are we talking about cocaine? Are we talking about opioids, marijuana, alcohol? Where are you at? What are you
Work
looking at?
I work with everything. In Southern Indiana, the biggest problems we have are meth, alcohol, and opiates. Those are kind of like the three that I deal with the most. Meth and alcohol probably being primary. So yeah, that's just kind of a location thing. I know it kind of like varies. Opioids gets a lot of the focus right now because it's killing a lot like younger people, right? And the risk of overdose because of fentanyl contamination and stuff is really high. So yeah, I kind of ended up in addiction because my master's program was a dual master's, so I ended up having that background. And we lost a addiction counselor, and they asked me if I wanted to do it. And when I started, because I used to see addiction as a therapist as like a barrier to what I wanted to work with, which is like all these other mental health symptoms. So I kind of avoided it. But once I started working with it, I mean, I totally fell in love with it because of its complex sort of like relationship to trauma and the awesome deep communities that sort of exist and people's stories and seeing them connect with each other, because the best treatment for addiction is group therapy, right? So I run a group, and yeah, it's my favorite thing, right? So I'll always work with that in some capacity too, even though it wasn't the OCD that I went in wanting to work with the most.